Hi guys, I really love the verse Jeremiah 29:11. For I know the plans I have for you, declares the Lord. Plans to prosper you and not to harm you. Plans to give you hope and a future. And I hope if you have never heard that verse before, that you'll look it up and you'll kind of utilize it if you're having any low times, right? You're going to go through nursing school and you're going to think, I don't know what I'm doing. I don't know why I got myself into this. God has a plan for you. Okay, he's not going to harm you. He's going to give you hope and he's going to give you a future. So look up Jeremiah 29:11. It really resonates with me, and you'll probably actually hear me utilize this verse multiple times as you have me as an instructor. So let's get started talking about mobility and immobility. Immobility complications arise pretty frequently when our patients are hospitalized. If you can think of someone that does yoga, maybe you do yoga. When we think about mobility, how would we define mobility? Well, it's that freedom of movement, the independence of purposeful movement. A functional musculoskeletal and nervous system are really the two essentials for mobility. So when we think about characteristics that we can display with yoga, we have flexibility, we have muscle strength, muscle tone, improved balance, improved performance, improved cardiac health, brain function, memory, protection from injury, right? Lots of characteristics that can be displayed when we have a good functional musculoskeletal nervous system. But let's switch gears a little bit and think about our immobile patient and what are they lacking? They're really lacking that freedom of movement. The longer our patients are immobile, the increase in complications that occur both physiologically and psychologically. So you can see there all the core, right? We have that core when we have that freedom of movement. When we lose that core with our immobility, that's when complications can start happening, especially the longer we are immobile. So let's start with body mechanics. And this is really the coordination between the musculoskeletal system, again, and the nervous system. We have to think about our own body mechanics as well as our patient's body mechanics. And we saw this a little bit in lab last week as far as that ergonomics. You'll hear that word, right? Making sure your body is in proper alignment, balance, and movement. So when we think about alignment, we want to keep our body and our patient's body in proper alignment. For our body, we need to widen our feet, shoulders width apart, bending at our knees, tucking in our pelvis, and then keeping our head up. This keeps us aligned, and we do have to remember that even with our patients. That's going to help reduce the risk of injury, not for just you, but also for your patient. Alignment also helps the body move. It helps it function with strength and with efficiency. When we think about balance, this is our center of gravity. The lower the center of gravity, the higher the stability, right? If we can keep our center of gravity low, we're going to be a lot stable on our feet. And then body movement, bring the patient to you. Raise the bed, go face to face with the patient when transferring, pivot feet in the direction of the movement instead of twisting. And we will have the opportunity to kind of look at some of this in lab this week. Healthcare workers have a high incidence of back injuries because we just forget or neglect to use our body mechanics. So all of these things on this slide really regulate movement. Most of these you are familiar with. We know the skeletal system. We know what our joints do. We know what our ligaments and our tendons do as far as connecting to bones. And then we also know what our bones do as far as bones to our muscles, muscles to our bones, maybe our bones to our bones. The only one that you may not be familiar with is proprioception. You can see that in that bottom left. So think about proprioception. What is that? This is the idea that we know where our extremities are in relation to our body without even looking. So if you close your eyes and you move your arm up and down, you would know where your arm is even when you're not looking at it. So some factors that may affect mobility: alterations in muscle, an issue with our muscles, right? If we have poor muscles, we haven't been using our muscles, that's going to affect our mobility. Injury to the musculoskeletal system, maybe some type of traumatic injury from a car accident. Poor posture is going to affect our mobility, right? Think about those elderly people that are kind of hunched over, right? That poor posture. I always feel like they're going to fall face forward because of that poor posture. Impaired central nervous system, maybe a spinal cord injury or something. Health status and age. Again, maybe it's that 80-year-old grandma with years of diabetes that has peripheral vascular disease, right? All of those things are going to add up to factors that are going to affect that mobility. And then bed rest, right? If we're just laying in bed, our muscles are atrophying, our posture is getting poor, we have to rely on some interventions that might restrict our patient for therapeutic reasons. So making sure that we continue, if they are on bed rest, how are we going to get them to not lose all of their mobility? So let's look at some systemic effects of immobility. The first one we're going to look at is the metabolic system. And you can see their decreased rate, endocrine, calcium absorption. So let's look at it here. So metabolic changes is a broad area. This could include altered endocrine system, decreased basal metabolic rate, altered nutrition, maybe a decrease in appetite, changes in protein intake are going to just result in that muscle loss. Weight loss or loss of weight, reabsorption of calcium from the bones, that can cause our osteoporosis if our calcium is reabsorbing away from the bones, and then negative nitrogen balance. As far as respiratory, that's the next systemic effect we're going to talk about. So immobility can decrease respiratory movement, resulting in decreased oxygenation and carbon dioxide exchange. Immobility causes stasis of secretions, which means it's just status quo, right? It's not moving, because think about your patient that's immobile. All of those secretions are just holding still. So stasis of secretion, decrease in the respiratory muscles, which could cause atelectasis or pneumonia. The first picture shows a great looking alveoli. So you can see it's nice and fluffy. All the air is going in. It's nice and open. This is a patient that even down in the bases of their lungs, you can tell they're taking nice deep breaths. When you're immobile or in bed, you don't take those nice deep breaths typically. You take shallow breaths that can cause those bases of your lungs to start collapsing. So when atelectasis occurs, we know the alveoli are collapsing. The surfactant in the lung sticks together. When that surfactant sticks together, less air movement occurs, which makes secretions occur in that area, which can lead to pneumonia. So alveoli collapse, surfactant gets sticky, surfactant sticks together, less movement of air, secretions start hanging out in that area, and it leads to pneumonia. So when we use the nursing process, we think about what would I assess with my patient who may have respiratory changes due to immobility. First of all, we're going to assess their lung sounds, right? If atelectasis is a concern, when I listen to the bases, what am I going to hear? Probably nothing, right? Because remember, their surfactant is sticky and it's making that air movement lessened. So it's going to sound absent. If they have pneumonia, what will I hear? I'm going to hear crackles. And why would I hear crackles? Because there's increased fluid because of decreased blood flow from the lungs that are going to cause that little crackly sound. If we have increased mucus production and stasis, what might we hear? That might be wheezing. We're going to also assess respiratory rate, tachypnea, that's fast breathing, or bradypnea, that's slow breathing. We're going to check a pulse ox. Remember, we are not only concerned about air getting into the lungs, but is it able to transport to the tissues? Remembering that diffusion and perfusion are essential. What about their mental status? Does our brain need oxygen to function? If I am not oxygenating well, what's going to happen? I'm going to get confused, maybe disoriented, maybe have a decreased mental ability. So we've done our assessment, now we need to analyze, right? We're going to combine the data that we've collected and we're going to see what's going on. If they have atelectasis, what do I see? Diminished breath sounds, tachypnic or fast breathing. The pulse ox may be lower, quality of breathing may be shallow. Then we need to make a plan. So what could our plan be? What are our goals? Remembering that our goals must be SMART. So maybe our goal is that patient's pulse ox will be above 95% by end of shift, right? Patient being the specific, it's measurable because it's a 95%. Is it realistic and attainable? Yes. And do we have a time frame on it? Yes. So that is a SMART goal. Then I have to implement the interventions to prevent an unanticipated problem for immobility, sorry guys, with a respiratory issue. We may want to implement our incentive spirometer. We need to expand the lungs, bring the oxygen in, and keep the alveoli from collapsing. If we do all that, is my patient's pulse ox going to be greater than 95%? Yes, it should be. We may need to start oxygen therapy depending on how our patient looks. We may need to change the position of the bed. Maybe they can't walk, but we could raise the head of the bed up to the 90th percentile in order to help expand those lungs. Try laying down and breathing, and then try sitting yourself up and breathing. When you sit up, you can get really good lung expansion. So change in position is always a great intervention with our respiratory patients. You may use a turn cough deep breath. So we roll to one side, take several deep breaths with a cough, and then roll them to the other side, right? That's just getting those secretions that are stasis to start moving around. And then we're going to evaluate, were the interventions I implemented effective? Is my O2 sat 95% or higher? If not, then again, we're going to start the whole process again. Do assessment, analyze, plan, implement, and then evaluate. All right, let's talk a little bit about cardiovascular, specifically orthostatic hypotension and our thrombus. So prolonged immobility can cause alteration in cardiovascular system. Orthostatic hypotension occurs with venous stasis. So remember, our patient is immobile. The venous blood is sitting still. The blood flows to the extremities and just hangs out there. So we have more blood in our extremities, less blood in our hearts, lungs, and brain. And this could lead to orthostatic hypotension. Decreased cardiac output is poor cardiac effectiveness, right? If we have poor cardiac effectiveness, it's going to increase the workload of our heart. Increased oxygen requirements is also a cardiovascular change. The longer a patient lays in bed, the more oxygen requirements the patient may need. So monitoring their pulse ox will be essential. The biggest focus for this system that we're going to look at is the increased risk for thrombus formation. This can be very common with immobility, and you will hear it called a DVT or a deep vein thrombosis. You may also hear it called VTE, and that is when our DVT moves, and that can be really scary. You can have a DVT in your leg, it'll get comfortable, it'll cause redness and swelling, but it's really not that dangerous. It becomes dangerous when it moves. However, if my thrombus moves and becomes an emboli, then it's really dangerous. The most common location that these go to is the lungs, which can be life-threatening. So let's work through our nursing process if our patient has a DVT or a deep vein thrombosis. If I want to assess for a thrombus formation, what do we need to assess? We need to assess the extremities. We can check the legs to make sure the color is okay. Are the pulses intact? Is there redness or swelling on any part of the back of the calf, which is the most common location? If we're concerned that the clot may have moved, what system would we need to assess? And we would need to assess the respiratory, right? Because that's typically where those emboli go, is to the lungs. So then we're going to analyze the data we've collected. Hopefully they haven't developed a clot, but if they have, we know that they will have redness, swelling, and pain, and we need to address that. So what is the plan? The biggest plan is prevention. So by the end of my shift, my patient will not have a blood clot or a deep vein thrombosis, or if they have a DVT by the end of my shift, it will not have moved. Okay, so those are my goals. So now we need to implement. What's the best thing you can do to prevent a DVT? We need to move. That may be easier said than done with some of our patients if they are immobile. If they are mobile, we have to get them moving and out of bed. If they can't get out of bed, then we've got to do some range of motion, moving all of their joints, their major muscle groups to prevent this thrombus. So what's the difference in active range of motion and passive range of motion? Active range of motion means my patient can move on their own. They can actively move their arms, their legs, their joints, those major muscle groups. Passive range of motions means that we have to do the movement for them. The other implementation to help blood movement in our immobile patient is the application of TED hose. So those are those tight stockings that are going to help return of blood flow from the lower extremities back to the heart. Or we can use SCDs, sequential compression devices. Many massages for the lower extremity to get that blood flow back to the heart. So TED hose, SCDs are really tight things that go on the legs. That's going to make that blood push back towards the heart, the lungs, and the brain. When we're done, we will evaluate, did my patient have a blood clot during my shift? All right, musculoskeletal changes. Remembering if we don't use our muscles, we're going to lose our muscles. So musculoskeletal changes can include muscle effects. Patient loses that lean body mass. You can have muscle atrophy and contractions. So our immobilized patient lose lean body mass, the muscles weaken, and atrophy occurs. Think about you exercising regularly and then taking a few weeks off. It takes a few times to get back where you were because those muscles have weakened because they haven't been used. Now think about the patient that has hip surgery and is immobile for a few days. They will have loss of muscle mass in those lower extremities. Depending on the length of the immobility, this can become very serious and patients can develop contractures. Contractures are when the tendons and the ligaments tighten as the muscle atrophies. These contractures will pull the body almost in a fetal position, pulling those hands up to the chest, causing the hands to come into a fist position. So you can see on that bottom right picture where his hands are kind of contractured, right? They are bent over, they're up to his chest because all of those tendons and joints have atrophied around those muscles and they've contractured. So let's say our patient has developed some contractures. Let's talk about assessment. We're going to meet resistance if you attempt to pull those arms or legs from the position of the contracture. Is the injury or infection a concern with these patients? Absolutely. As their hands become more contracted and go into that fist position, it is tight and it can become warm and moist and a breeding place for fungus. Their fingernails continue to grow, and if you make a fist yourself, you can feel that fingernail digging into the palm of your hands. We can see these contractures at the elbows, the shoulders, hips, knees, ankles, and feet. Then we're going to analyze our data and see how significant our patient's contractures are. We'll do a plan, right? We're going to try to revolve around prevention of these contractures. If we can't prevent it, then we will work with the patient to keep them from getting worse. Interventions may be range of motion. If they're unable to do this by themselves, then we need to do passive range of motion at least every 2 hours. Is this feasible for a nurse? No, but it's good teaching points for families, right? If they have a loved one in there, a daughter, a spouse, a caregiver, we can teach them how to do passive range of motion. Remember, we can empower our families when we get them involved. So teaching our families about the major muscle groups and how to perform those range of motion exercises. Bracing is another intervention you may see with these patients. We will put these on every 2 hours and take them off for 2 hours to give them time to do stretching. So we'll brace. So for instance, our guy with the fists made, right, we may put a brace on there to try to stretch out those fingers, joints, and ligaments for a couple of hours to see if that helps. But we'll just do it for a couple of hours and then we'll take it back off. Other complications we can see within the musculoskeletal system include osteoporosis. So this does take time. This may be a patient with a spinal cord injury that has paralysis with a lack of movement in those muscles for years. This is weakening of the bones. Disuse osteoporosis are fragile patients, and we need to be very careful with them. We can cause injury by pulling or tugging on those patients. And you can just see by the picture there how all of that is just kind of that calcium is getting pulled and the last one I want to talk about is joint mobility or foot drop. This is caused by a lot of pressure on the top of the foot when they are laying on their backs in bed. So this is also another type of contracture. So it's that inability to pull up the toes. So what can we do to prevent this? We can use a foot cradle, which is like a wire guard that goes over the feet that keeps the blankets from laying on the feet for a prolonged period of time, or a foot tent. You can see those there. That top picture is your foot tent, right? It's keeping the blankets off. And that bottom thing is a foot guard so that those toes have the ability to be in the upright position. We talked a little bit about this in lab last week as far as when you make up the bed and your patient's in the bed, making sure you're not like a hotel bed where you get in and it's so tight in there you can't move your feet around. So making sure they can have that mobility of their feet so they don't get the contractures that causes foot drop. Urinary and bowel elimination is the next one that I'm going to talk about. And when we talk about urinary elimination changes, we can talk about urinary stasis. Remember, this is our patient that is immobile, meaning the urine goes into the bladder and just sits there for way too long when a patient is immobile. They can lose that sensation of when they need to void with prolonged immobilization. It also can depend on how much they're drinking. When you are immobile, you tend to drink less. They become dehydrated and don't have that sensation when they need to urinate, and the urine becomes stasis. When the urine just sits in the bladder, it increases the chances of infection, so they have an increased prevalence of UTIs. They also can develop calculi, which is just a fancy word for stones. When the urine sits stagnant in the bladder, the more likely those stones will develop. We have to also watch their fluid intake, and this is really going to depend on what's going on with our patient. Most patients will take in an adequate amount, but some patients may not be able to take in that much fluid. So for instance, our patient with congestive heart failure, we're not going to be able to give them a lot of fluid, right, because they're already in fluid overload. So we may have to just be mindful of the amount of fluid we can give. So our mobile patient has some urinary changes. So we're going to do an assessment. We're going to start looking at the urine, whether they have a Foley catheter or they're getting up or using a bedpan. We want to assess the urine color, odor, if it's clear or cloudy. Do they have pain with urination? That could indicate some type of infection or stone. We also want to include the peri area. An immobilized patient will have difficulty keeping this area clean, which could lead to infection. So either UTI or a yeasty type infection. Then we're going to analyze. We've collected our data, we've determined what is happening, and we're going to make a plan. So our plan may be that we need to increase their fluid intake. My patient will drink 2.5 liters of water by the end of my shift. And then we're going to intervene. What's that intervention going to stem around? Pushing those fluids, right? If we want them to drink 2.5 liters, we need to push the fluids. We may need to be creative with some of our patients to get them to drink. Maybe every time there's a commercial break, they have to take a drink. Or maybe we will put an 8-ounce cup of water beside them and tell them they have an hour to drink it. And then an hour, you'll come back with another cup. If they struggle with getting enough fluids, we may have to do some IV fluids. And then we're going to evaluate and make sure our interventions were effective. When we think about gastrointestinal changes, we can think about decreased peristalsis. What is peristalsis? It's the action of contraction. The bowel pushes fluid and food through that area. When this decreases, it causes several complications. Constipation is the biggest concern. When peristalsis slows down, the stool sits in there longer, it becomes hard, and it makes it more difficult for that patient to pass. Because of constipation, they can develop impactions and even diarrhea, which is just leaking around that hard stool. Their immobility develops this decrease in peristalsis, causing constipation. But the other factor that plays into this is their decrease in fluid intake. When you're not drinking enough fluid, your stool does become harder. So make sure you're looking at both of those factors when we're thinking about our GI changes. Integumentary is that last one that we're going to look at. So when we think about integumentary changes, we are looking at our patient's skin. Increased pressure on the skin can happen with our immobilized patients. Decreased circulation, causing tissue damage and ischemia. When you lie down on your back, there are areas we have to be cautious of, and it's those bony prominences. The big one is our coccyx, which is our bottom, right? When we lay long enough on this area, it cuts off the blood flow, and eventually those skin cells start to die. Tissue is damaged and ischemia can develop. Death of these cells causes no blanching. So when I say blanching, if you press your finger on the area, it turns white and then pink again. Areas that don't do this and stay white are the scary areas that we worry about, pressure ulcers. Older adults are at great risk because their skin is so thin. So let's look at our nursing process. We're going to assess. So positioning will affect your assessment and where your concerns may lie for our integumentary changes. We have to assess all of the skin because immobility causes these pressure points. Positioning will affect your assessment. So then we're going to analyze the data and come up with a plan. The plan may be that they have no pressure ulcers during your shift. Then we're going to intervene. So what do we need to do? What do we need to implement? We need to turn our patients every 2 hours, change the type of bed they're on. Maybe we need to do a pressure release bed. Put one sheet under them. The more we have under them, that could get bunched up. Make sure the skin is staying dry. If they have incontinence of urine or stool, that moisture can cause injury. And then what about diaphoresis, right? If they're sweaty, we may need to change that linens quite frequently. Pad the areas. We can use dressing, foam cushions on those areas of those bony prominences. And then we're going to evaluate. Did you make it through the shift with no pressure ulcer? So let's look at the risk sites for pressure injuries. If we have a patient in supine position, where are those pressure points? We can think about the back of the head, the shoulder blades, the hips, the coccyx, the back of the heels, and the toes. And you can see those there. What about our patient on their side? We have to consider their ears, their shoulder, their elbow, hip, thigh, external and internal, heels, and ankles. So you can see them there, right? All of those, you can see your internal and external thighs, right? If I have my skin laying on top of skin without some type of a pillow or barrier, right, it's still going to cause a pressure point there. If our patient is prone, right, that's on their stomach, this doesn't happen very often, we do have to consider their knees. What about our patient in semi-Fowlers or high Fowlers? Those are the different positions that we can put our beds. Semi-Fowlers is somewhat up, and then high Fowlers is that 90-degree. And we can think about head, shoulder, sacrum, and heels. So this right here on that bottom picture is probably your kind of semi-Fowlers because it's not a 90-degree angle. But think about all those things that are still right on the bed. What about a wheelchair? Does that change our pressure points? We may need to assess the back of the calf. So we have to assess all of the skin because immobility causes these pressure points. So we're going to do all of the skin assessment. We're going to analyze that data and come up with a plan. The plan for the patient will be that they'll have no pressure ulcers during the shift. And in order to do this, we need to implement several things. I think we've already talked about all this, right? Turning the patient, changing the type of bed, one sheet, skin stays dry, pad the areas, and then evaluate. So lying in bed or being immobile for an extended period of time affects our neurological and psychosocial system. So emotional response, which is usually because of the inability to take care of themselves, they kind of lose their autonomy. They can be on this roller coaster ride of hostility to giddiness, to fear, to anxiety, right? Immobility can also alter our sleep pattern. When you lie in bed all day, all night, it affects your sleep and your circadian rhythm, which can affect your psychosocial being. You can have changes in coping, which can cause behavioral changes, which include withdrawal, inappropriate laughter, or passivity. So let's look at some developmental changes that can occur with each of these age groups. So we'll look at infants, adolescents, adult, and older adults. Immobility in infants may show slower progression in gross and fine motor skills. So if they have some immobility, they progress with their gross and fine motor skills pretty they lift their head, they roll over, they sit, they crawl, right? All of those things happen kind of within that first year of life. But if they're immobile, they may not be able to do that. So they may be slow with some of those gross and fine motor skills. Infants develop milestone cephalocaudal, which is head to tail. So for the immobile infant, body alignment and posture may just be unbalanced. When we think about our adolescent population, immobility may alter growth spurts. You may see delay in development or independence. Social isolation will be real for this population. The adult and older adult, we can see alterations in balance resulting in increased falls and possible injuries. They've studied loss in bone mass resulting in weaker bones. They have decreased coordination and decrease in independence and more relying on our families and staff. So how do we position the immobile patient? Remember, we talked about this at the very beginning. Body alignment is huge. So to help relieve pressure on the back and the heels for people who are confined to our bed or who sit for most of the day, this is a really good position. You can see how their hip joints are aligned. Okay, so we need to make sure that they can stay aligned to decrease injury, decrease pressure ulcers. So other positioning techniques that we can talk about. Supine, again, is on your back. Prone is on your abdomen. Again, you're not going to see that very often. You can put a pillow under the legs, which can help relaxation. It promotes drainage from the mouth. If there's oral surgery, this may be why you are on your belly. Right or left lateral sides. On the sides, most of the weight on the dependent hip or shoulder. This is typically your good sleeping position. You can see high Fowler's there. It's almost a 90 degree, 60 to 90 degree. It promotes your lung expansion, prevents aspiration during mealtime. Fowler's is going to be 45 to 60 degrees, so just a little bit lower. Semi-Fowler's is going to be your 15 to 45 degrees. So that's just raising the head of the bed up a little bit. Trendelenburg, we'll put our patients in Trendelenburg with hypotension, postural drainage, maybe venous return, right? If they're not having enough blood flow back to the heart, Trendelenburg is a good one. And then Sims, you can see Sims there. Sims is often used for paralyzed patients because it reduces pressures on the buttocks and the hips. Many people find this position of comfort. You're also going to use Sims position if you're administering an enema. So Sims is for paralyzed patients and enema administration. So protective positions, we want to make sure we're changing our patient's position at least every 2 hours. If the patient can't do this themselves, then you have to help them. You can use rolled towels, wedges, or pillows to aid in positioning. So we've got our patient there on the slide, rolled on her right side. We're just going to use that pillow so that she stays on her right side for a couple of hours. And then we'll come back in a couple of hours, and then we'll move her either to middle or we'll move her over to her left side and take that pillow out. Assistive devices for walking, we can use if the patient has altered gaits or impaired ability to ambulate, they may be required to use assistive devices. So why do we use this? They help with gait, it reduces pain or discomfort, and increases our function in our lower extremities, improves balance, improves posture, facilitates movement. So let's look at each of these a little bit closer here. When we look at a gait belt, this is a wide belt that helps with stability. It needs to be fastened snugly on the patient with just enough room for the caregiver to slip their fingers under the belt. So they can put that under the belt and they can nicely lift the patient up with that gait belt. That's helping prevent injury to not only your patient, but also to the caretaker. When we think about a cane, this is increasing stability and improves gait mechanisms. Single point or 4-point canes. You can see both of those there. The thing with the cane is you have to just be mindful of like rugs on the floor, anything that would be a tripping hazard. If the patient's going to trip on it, the cane is going to trip on it. When we think about walkers, these help assist with ambulation of those with balance issues or weakness difficulties. Provides a wide, stable base with great amount of support. You can have 2, 4, or no wheel walkers. Keep the home, again, free of clutter, loose rugs, stray cords, things like that that are tripping hazards would be a problem. And you can see my picture, that's a no wheel. You can have 2 wheels on the front, no wheels on the back. You could have all 4 wheels, or you can have no wheels. And we'll look at some of these in lab this week. Crutches typically are used for younger patients because they really need that upper extremity strength to be able to use these. We have to make sure we're fitting them accurately. Several gait options. We can do 2, 3, or 4-point gaits, swing through gait, swing to gait, and we'll go over each of these in lab this week. And this is how you would measure your for crutches. The top of the crutch should be about 1.5 inches to 2 inches below your armpit. while standing straight up. And then you've got to have your elbow at a good angle so that you're really using your arm muscles, not your armpit muscles, to get around. Once we have the crutches measured correctly, we have to follow the prescribed crutch gait. So the different types of gait we've talked about, right? 2-point gait, the patient has partial weight bearing on both feet. The patient moves a crutch while moving the opposite leg at the same time. This just really mirrors normal walking movement. The 3-point gait, the patient bears all weight on one foot while using both crutches. The affected leg should never touch the ground. Your 4-point is when the patient is able to bear weight on both legs, but they alternate each leg with the opposite crutch. So 3 points of support are on the floor at all times. And then you can see swing through, right? You put the crutch in front of you, kind of swing through it. We'll see these in lab this week. Ascending and descending stairs is going to be a lot of teaching when you're talking about patients with crutches. Sitting in a chair, right, you can see how we can't put any weight on that right leg for our lady. So we're going to get our crutches, we're going to stabilize it with our left hand, reach for the chair, and then have a seat. So interventions for a patient who begins to fall when assisted to ambulation. This is where you want to place your feet really wide apart, 1 foot in front of the other. I would really like stand up as you're listening to this and try to do this. Rock your pelvis out on the side nearest the patient. So if your patient is on their right side, kind of put your pelvis to nearest the patient. Grasp that gait belt. Support that patient by pulling her weight backward against you, and then just gently sliding them down your body to the floor, making sure you're protecting their head. And then you're just going to stay with your patient there and call for help. And this is kind of what it looks like, right? 1 foot in front of the other. You can see the nurse back there, 1 foot in front of the other. You've kind of put your hip into their coccyx, and then we're slowly getting them down to the floor safely. So we think about application of hot and cold. We do have some considerations when we use heat or cold application. We have to be cautious with the very young and the elderly because the skin is thin and fragile. Immobile patients won't be able to escape the application if it's uncomfortable, which could put them at risk for skin injury, right? If our patient's immobile and we put a hot pack on them and it's burning them, they're immobile, right? They can't move it. So it could put them at risk for skin injuries. Patients with impaired sensory perception may not feel the heat or cold because of their numbness, pain, or burning. So avoid prolonged exposure that can result in tissue damage, burns, reflex vasodilation. We don't use cold applications for patients with cold intolerance, vascular insufficiency, open wounds, or disorders that are aggravated by the cold. For heat-specific applications, considerations may include if they can't get it off, it could burn them. No heat 24 hours after an acute traumatic injury because they have active bleeding, inflammation. Bony prominences are more sensitive to heat. So just a couple of things, considerations when you're thinking about heat or cold applications. So we talked about SCDs, applying those sequential compression devices. This is protecting our patients from those deep vein thrombosis or DVTs. It improves blood flow in the legs of those that are immobile. Inflate with air with one leg at a time, which imitates walking to prevent those blood clots. So you can see on that bottom right side there, one on each leg. So envision that the right leg inflates and deflates, and then the left leg inflates and deflates. So it's mimicking that walking while they are immobile in bed. When we're applying anti-embolic elastic stockings are our TED hose. This helps again with blood pooling and blood clots. We have to remove them every 8 hours to assess for redness, warmth, or tenderness. And you can see how we measure for those there. You will have the opportunity to put these on in lab this week. When we think about positioning aids, you can see the draw sheet under the picture on the right. You can also see the trapeze on the picture on the left, right? It's just helping position our patient without getting any shearing or friction. The patient's ability to help with the trapeze is important, letting them help move them up in bed. If we're just using a draw sheet, making sure actually there's somebody on that other side that's also helping. All right, I'm going to talk a little bit about culture of safety and how important it is within your work, and then how to follow it. So we want to assess our patient and see if it's safe to move them. We can ask them what is their own physical ability, right? Try to get them to help you. How much can they help you? What can they do? If our patient is a total patient care, that's going to change how we look at our situation. If our patient is aware and awake and can push off with their legs, pull up with their arms, that's going to make a difference on how we assess the situation. We can look at the patient's chart. Are they bed rest? Are they in assist with 1 or 2? What does your previous nurse tell you? Assess our patient's ability to understand. Make sure they understand what's happening. We don't want to startle them. We want them to be able to follow the commands that we tell them. Some facilities will use algorithms, so those yes/no boxes. Can the patient assist? Yes, go here. Can the patient stand? No, go to this side. Can the patient push with their legs? Yes, right? It's that algorithm that you can follow. This is a tool that can really help us determine if we need additional equipment or staff. Determine the number of staff or equipment needed. Do we need a Hoyer lift and 2 staff members? Making sure I know this before entering the patient's room will make the transition a lot safer. We want to assess the area for any obstacles. Is there oxygen? Do we have tubing that goes to the bathroom? Are they on IV fluids? Is the pump plugged in? Just any obstacles that might be in your way, you just need to be mindful of. Make sure you're planning ahead, right? It's important. Really go through the process in your mind before the attempt, and it's going to make it go smoother and safer. Explain the procedure to the patient. Some other considerations may include pain meds, the height of the bed, right? Bring the height of the bed to you. Wheels locked, well, unless you're trying to get them out of bed, then don't bring the head of the bed up. Are the wheels locked? Are the tubes secured? Prevent friction, right? We can do that by using our draw sheets. Don't jerk or pull on the patient's limbs. When we manually lift and transfer a patient, this puts the nurse at risk. We should never lift more than 30 pounds. We all can do that, but we shouldn't do that. So current evidence shows that many nurses transfer to different jobs and even leave their profession because of work-related injuries. This can happen to us, and it will happen to us if we put ourselves at risk. So don't take the precautions that are in place and utilize them. Interventions have been developed to reduce the number of risk-related injuries. Hospitals have put several interventions in place to help reduce these injuries. Lift teams, that's really their only job. They lift patients in bed, out of bed, from the chair to the bed. That's their job. Special equipment, hospitals are mandated to have special equipment available. Some hospitals will have a no lift policy. Lateral transfer from bed to bed, a traditional draw sheet is okay, but can cause some friction with the sheet on sheet. So how do we reduce friction? We can use a transfer board, which just has this really slick side. We can use air-assisted devices, which is just a minimal strain on the nurse. So different evidence-based devices that we can use. Before transferring a client, the nurse must determine the amount of help they will need. So stand assist and repositioning aids. The patient can sit to stand, but make sure the patient has that ability. They need to be strong enough to push themselves up, brace them at the knee, and cushion their back so they feel secure. Slide or transfer boards, transfer chairs, powered full body lifts. These are all assistive devices to try to get our patient from one place to another. The powered full body lifts are helpful if your patient has fallen to the floor. There's actually kind of a cool video there that you can watch. If they fall to the floor, you leave them there, right? They're safe. You can do an assessment. The last thing you want to do is have your patient break a hip and then you try to pick them up. But you put this under them, this power full body lift. You put this like plastic thing underneath them and you turn it on and it literally just blows up to the height of the bed. And then we can transfer them back to bed. Here is your slide board. So we're transferring from bed to bed or wheelchair to bed or bed to wheelchair. We can use that at any point. Usually does take 3 or 4 members though. Don't try to do that by yourself. We talked a little bit about those. I'm going to keep going. So you can see the lateral assist, right? We have them there. We're just going to move that whole thing over and they're going to go from bed to bed. The trapeze is helpful if the patient has a upper body strength. Here's a full body lift, the Hoyer in that bottom left, where we just put them in a sling and it lifts them from the bed, from the chair into the bed, things like that. And then we can do this stand assist, where they literally have the ability to hold on to those bars, but we can wrap them up so they can stand and assist us. So when we think about safety guidelines, make sure we're communicating clearly, right? Let Mr. Jones know exactly what's happening. Again, mentally reviewing those steps of transfer, assessing your patient's ability to help, determine the assistance needed. Do I need 1, 2, 3 people? Raise the side rails on opposite sides of the bed so they maybe aren't falling out the other side of the bed. Make sure you arrange your equipment, evaluate their body alignment, understand the equipment, educate the patient. So usually when I communicate clearly as well, I count to 3, right? 1, 2, 3, we're going to move, right? Give directions, communication's clear, you know exactly what's going to happen. So ergonomics, right? Center of gravity is the center of mass. It keeps you stable. When the human body is in the upright position, the center of gravity is the pelvis. To lower the center of gravity, you bend your hips and your knees. You tighten your abdominal muscles and tuck that pelvis. Don't allow any twisting. So proper and improper way to pick up an object there. You can see bending the knees, lowering your gravity, center of gravity so that you can pick that up versus using your back to pick it up. So assessment criteria, what is the patient's level of assistance? Independent patients should have a gait belt. Partial assist, the patient's doing some of the work, sit to stand or stand assist. Dependent is the patient's really unable to help at all. They need total assistant like a Hoyer lift. Weight bearing capacity could be full, partial, or none. If they can fully bear weight, then all weight can be used. Partial is usually charted as a percentage, and then none means there's no weight that they can utilize. We can look at upper extremity strength, patient level of cooperation, weight, height, and then other factors as far as assessing. And then, of course, we always evaluate. Did the patient's goals get met? Have outcomes been met? If not, why? So asking those questions, why? And that concludes chapter on mobility and immobility. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.